As I say, my name is Cristina Bescos. I'm from Philips Healthcare. I manage the European programs in the telehealth area. What I'm going to present today is our population health approach and giving you examples of the UK with real results of running services. So these are not pilots or European funded projects, this is really real life services. We always start with the presentation with the current situation. I think at this time of the afternoon you are all aware of the needs of transformation and also of the urgency of this change. So it's time for radical shifts in healthcare. And the challenge is mainly all the providers. We are increasingly held responsible of outcomes. And the problem is we just don't know where, when, or how the care is happening. And this is, I'm very glad I had my talk just after Mr. Kagalidis because it fits very much into my discussion. So we used to have a very fragmented healthcare and we need to move to a continuous health. This is the concept we are pursuing, this continuous health in the health management approach. So to have continuity across settings, across people, data and time. So it goes from healthy living, prevention, diagnosis, treatment and home care. We have to think, I mean, life is one, and your health is also part of your life. It's not fragmented. So when we talk about population health approach, and we are Philips, you would probably base that. Do we have a pointer, maybe? I'll check. Yes, perfect. So there's one element, is the enable technology. So we do build software and hardware for high quality to communicate and ensure connectivity, but it's only one piece of the whole puzzle. So you need to have clinical sound programs to target the populations with the different needs of the population, and this is also supported by data analytics so that you can really prevent and predict certain behaviors and react in time. And not the least, the last element of the puzzle is this strategic consulting. When you need to make such a radical change, it's very important to have support in these transformation steps. So in the design of the program, in the change management integration, and incorporate the learnings, both the failures and the successes of other systems. So for us, population health means giving elements of this puzzle in all the areas. And that means to say one size doesn't fit all. You need to tailor programs that fit different population needs. So if you have acute patients, they may need more intensive care. If you look at prevention, you have a different focus, I say, in needs and also in the resources available for that population group. When talking about chronic patient programs, so we are dealing about specific diseases like heart failure, COPD, or diabetes that was mentioned before, but many times you have combinations and you really in the end have to customize those care plans to the patient needs in order to manage their own health. So what we call them, so we don't talk anymore about patient management programs, we talk about supported self-care. And that means that the patient takes responsibility. This is an example of a system. So what you need is to provide support in terms of monitoring, but also giving goals and coaching and education and all the tools that are needed to manage your own condition at home, but feeling supported on the other side. So I'm going to go to the example of Liverpool. So I'm going to explain the program, but also the results and the data analytics based on those results. So Liverpool is a city in England, so you all know about from Beatles. They have important health challenges. First one is 30% of the population live with a chronic disease, a long-term condition. Almost 26,000 older people have difficulties in their day-to-day activities, and you'll see around 86% of the population have difficulties with active life, so it's a problem of sedentarism. these challenges are common. I mean, you've seen them in other populations. Liverpool has also a tremendous problem with respiratory disease in the population, so that you will see also in the results. So the Liverpool commissioning groups have commissioned, let's say, a healthcare service that is not only technology, as I say, it's based on a clinical hub. And these clinical hubs, you see these ladies, these are the people attending the hub. So this woman is a matron, so this is the highly skilled nurse who is able even to manage medication, while you have other ladies who are more on the technical side who can do certain calls to track the patients and support the recruitment process. So what I'm trying to say here is that this is not only technology, you need to have somebody on the other end also to react. So we have up to now more than 3,000 patients in the system, and we have defined together with all the stakeholders an onboarding process that I don't know if you can see with this resolution, but it basically starts with visiting the GP practices, so to agree on the governance and elements. Then there is case funding approach, so to select which are the patients suitable from this GP practice. There's a first telephone contact, then people are invited to visit the GP practice where they can see the system, touch it, and it's explained by the clinical people. And then there's an enrollment where a specific protocol is adapted to the patient needs, and then it goes to the installation at home and the monitoring follow-up session. The results of Liverpool. So we have taken a cohort of around 1,800 patients where we had data for 2 years follow-up. So you will see results of the changes in the different years. The population is very diverse. So one of the points I wanted to show you is that it's not all high-risk patients, not at all. So Liverpool is using a Wales model for risk prediction, and it has the prediction of an emergency admission in the next year. So if you look at the bands of 10%, most of the population in the system are even in the lower risk. Though if you look at this graph, also the green bar, it shows the relative number compared of the total population. So actually there are higher numbers in the relative side on the higher risk population, but of course if you have most of the population in any case, in any city, will be on those risk levels. Again, for the profiles of patients, just to show you a bit of the variety, COPD, respiratory, I mentioned before, is a big issue, but other diseases like diabetes and heart failure are shown there. So what I'm going to show you here is the changes of the risk level in the year. This is independently of our system. As I say, the Wales model is a risk stratification model based on 36 parameters. And in Liverpool, so every single citizen is scored. So we have data around 500,000 population. What do you see is within 1 year, red means same, so there's certain population that remain on the same risk level, but there's a lot of people who improve, which is not bad. I mean, in general, our healthcare system works. Some people go up. So even if you don't do anything, what it means is don't do anything, I mean, just compared to normal care, people tend to improve after an admission, which is normal because they are treated by the system. But we are having issues of capacity, and these figures will not look that well in the future years if we don't do anything. So what I'm wanted to say here is that it's important to show risk levels so that you know your population, but also keep in mind that these risk levels are dynamic. So what you can offer to a patient who is moving from here to here in 1 year or the opposite is not the same. So you have really to adapt your proposal also to the status of the patient, and it has to be dynamic. Again, more results, so let me explain you a bit of all those graphs. So what we did in order to create the evidence, and as I say, these are running services, so it's not a clinical trial, it's not a control situation, is to look for a match control. So every individual that was put on the telehealth services was matched to 3 individuals from the general population. We match on the age, we match on the gender, disease, we match on risk level, and also on the prevention index, so the neighborhood, in order to have similar results. So what we saw is, if you take the control group, this is a change in admissions from one year to the previous. The control groups also does better. So people who were admitted the previous year, they will have a reduction in general on the next year. But you see the intervention group improves much better. So sometimes when you do this pre-post analysis, you have this regression to the mean because you are just comparing like a control group. So what we are saying here in Liverpool is if you take your comparison of the intervention here to the control group, the change is around even 32% in the level of the 40% risk. And if you go even to higher risk level, the impact is even higher. Other results, as you see, we were studying what is the best service model for the population. So what we see is the longer in the system, the change in the admission. So there is effect also from the start of the system, so people who are staying less than 2.5 months in system. But the longer it is, the bigger is this gap. So that's what we are analyzing, what is normally the optimal level to be on the system, because the assumption at the moment is after certain months you can really down titrate the service provision, but keep some kind of support so that the patient still feels supported with less technology and less intrusive and less resources, but not completely leave them out of the system. The other element I wanted to mention is related to the cost. So this graph is related to the secondary care cost. And again, so blue is the control group and red is the intervention. What you see is the main gains are in the first month, but you keep this gain up to the continuation of the service. So there's a quick win effect, but you can maintain that. So at Philips, we define population health as written there, is the organization and accountability for the health and the healthcare needs of defined groups of people utilizing preventative strategies and intervention that are coordinated, engaging, clinically meaningful, cost-effective, and safe. From this long definition, I would like you to take 3 elements. One is define groups, so you need to know your population, be able to quantify them in scale, costs, and resources available for them. And that would guide you the design of the program. The second is the strategies in plural. So it means that, as I say, it's not one size fits all. You need to have multiple technology, multiple programs, and multiple support levels. And the third one is the cost effective. So you need to define your own outcomes. So for Liverpool or for the NHS programs, the outcome framework is related to the increase the patient and care empowerment, give the care as close as possible to the home environment, living well with the long-term condition, and also improve the workforce quality and sustainability. And you need to be able to track those objectives, because you are going to, all the partners, all the providers should really commit to those. So in the end, as it was said before, it's a matter of changing your business model based on these 3 pillars. So it's the population statistic, the programs you are defining, and the outcomes or how you are measuring it. So, as you say, I have given you the example of Liverpool. We are doing that in different systems of the NHS. This is the example of Lancashire and Bristol. So they are all different business or systems models according to their own needs and objectives. For that, we have a tool, and that is also part of this consultancy support that we are mentioning. So we need to have this population analysis and simulation based on the data we have collected from all these experiences, and understand the stratification schemes of the customers. And we can really manage the utilization cost and statistics in order to define the design of the program. So this is a quick way of defining rapid business scenarios in order to visualize really what is going to be your impact or saving model. And this way you can really have realistic assumptions of what your program will bring you, and not, again, stay in the level of expectations or very really unpredictable outcomes. So in conclusions from Liverpool is we have, as I say, data on 1,800 patients of different long-term conditions. There is a technology support, but it's a clinical service. We have provided evidence via anonymized control group matching every individual patient. We have proven reductions in emergencies and secondary costs ranging from 22 to 32% compared to this control group, with people above the risk of 25%. And also 90% of the patients feel more in control. And what you see is feeling more in control means that patients are 6.5 more probable or have less expenditures in healthcare in the next year. So the results is, you say, there are different models for the different acuity levels. You will have a bigger immediate impact on the higher level, but you should see impacts in all the levels. And it's also important that for the management of the population, you need to cover all the possible services. So say population health means scaling across diseases, acuities, and services. What is important is the service model and the impact forecasting, and as I say, the business model plan to make this system change. That's the end of my presentation. Thank you very much.